Hello and welcome to the Little Medic channel. Today we'll be talking about acute kidney injury. Acute kidney injury, also known as AKI, is defined as a clinical syndrome causing an increase in creatinine serum levels and/or oliguria or anuria. AKI affects 1 in 5 people admitted to hospital through the emergency department. 100,000 deaths each year are linked with AKI in the UK alone. 29% and 33% of people with an episode of AKI stage 2 and stage 3, respectively, die within 30 days of laboratory notification. With the right care, 30% of the 100,000 deaths could be prevented. AKI has a rise in incidence, which has been suggested to be attributed to the ageing population, the increase in prevalence of chronic kidney disease, the growth of imaging that requires contrast agents, and the rise in the amount of invasive procedures that lead to septic complications and hemodynamic compromise. So, given the rise in incidence and the importance of AKI, you may be wondering who is at risk of AKI. A patient is at risk if they have a history of chronic kidney disease, heart failure, ischemic heart disease, malignancy, liver disease, and renal tract surgery. A patient is also at risk if on this admission to hospital they have had surgery, IV contrast, a fall in blood pressure by 20 or more millimeters of mercury, urinary obstruction, rhabdomyolysis, malnourishment, or sepsis. Now we have found out who is at risk, how do we identify someone with AKI? Signs of AKI include hypertension, tachycardia, acrocyanosis, reduced skin turgor. Patients with AKI are usually asymptomatic, which can hinder diagnosis. However, symptoms do include dehydration, fatigue, exostomia, and anuria. Atkins staging is used to classify AKI. There are 3 stages, ranging from stage 1, mildest, to stage 3, most severe. Stage 1 is an increase of serum creatinine greater to or equal to 26 micromole per litre, or an increase from baseline of 150 to 200%, or a urine output of less than 0.5 millilitres per kilo per hour for 6 hours. Stage 2 is an increase from baseline of 200 to 300%, or greater than 200 micromoles per litre, or a urine output of less than 0.5 millilitres per kilo per hour for 12 hours. Stage 3 is an increase greater than 300% of baseline, or greater than 400 micromoles per litre, or a urine output of less than 0.3 millilitres per kilo per hour for 12 hours, or anuric for 6 hours. So, what causes AKI then? The causes of AKI can be split into 3 different categories: pre-renal, intrinsic or intrarenal, and postrenal. Pre-renal is a decrease in glomerular filtration rate due to a reduced perfusion of the kidneys. This can happen in hypothalamic states, for example, if a patient has an acute hemorrhage, has dermal losses such as burns, or has third spacing like in sepsis. This can also happen if a patient is in a hypothalamic state, where there is a low effective circulating volume. For example, if a patient has severe heart failure that leads to pump failure. This is also known as cardiorenal syndrome. Intrinsic is structural damage to the kidneys, in particular damage to the glomerulus, tubules, the kidney interstitial, or vascular damage. Acute tubular necrosis is the most common intrinsic cause of AKI and causes damage to the tubules due to ischemia. Other causes of intrinsic AKI is hypersensitivity reactions, particularly type 1 and type 4, which leads to inflammation of the interstitium. This is normally a response to medications such as penicillin, NSAIDs, and thiazide diuretics. Finally, onto postrenal. This is an increase in intratubular pressure and a decrease GFR due to an acute obstruction of the flow of urine. Most common causes of postrenal AKI in males is due to benign prostatic hyperplasia or prostate cancer. In females, kidney stones are more common. In both conditions, the urethra is blocked or compressed, causing urinary retention. So, who needs to go to hospital? patients who are suspected stage 3 AKI, have no identified cause of AKI, have a cause of AKI that requires hospital treatment, such as pyelonephritis or renal colic, sepsis, risk of urinary obstruction, hypothalamic with the need for IV fluids, a patient with a deteriorating condition that requires further monitoring, or a patient who has suspected complication of AKI. What do we do if we suspect AKI while in the hospital? We need to assess the risk of AKI, set targets for observations like heart rate, oxygen saturations, as well as urine output and consciousness level. Complete admission bloods, including OSCEs and FBC. Review admission bloods within 3 hours. Ensure a full set of observations are completed. Start a fluid balance chart and assess the severity of AKI. Now let's have a look at the initial management of AKI. This depends on the severity of AKI. Let's start with AKI stage 1. For stage 1, we need to ensure the following is met. 4 hourly urine output. 2 hourly if the patient is catheterized. 2 hourly observations. A repeat ABG creatinine electrolytes at 24 hours. For stage 2, the following needs to be completed. The patient should be catheterized. 1 hourly urine output. 1 hourly observations. Repeat ABG creatinine electrolytes within 12 hours. And a senior review within 6 hours. For AKI stage 3, the following needs to be completed. The patient needs to be catheterized. 1 hourly urine output. 1 hourly observations. Repeat ABG, creatinine and electrolytes within 8 hours. Senior review within 3 hours. And a referral to critical or renal care. After completing the initial management, it is important to complete the following. Identify the cause of AKI and treat it. Stop any nephrotoxic drugs. Common ones include imaging contrast, NSAIDs and ACE inhibitors. Review drug dosing. Correct hypothalemia. Treat any complications. Daily bloods to monitor AKI. For stage 3 AKI, monitor every 12 hours. And consider dialysis or filtration. The management in the community is slightly different, so let's have a look. Ensure to treat the cause of AKI. Stop nephrotoxic drugs. Review drug dosing. Advise on adequate hydration. Assess for complications. Monitor serum creatinine. And reassess regularly for the need for a hospital admission. So, when do we speak to a nephrologist? When there is an inadequate response to treatment, stage 4 or 5 chronic kidney disease, a history of renal transplant, uncertainty about management, a diagnosis that requires specialist treatment such as tubulointerstitial nephritis, glomerulonephritis, systemic vasculitis with renal involvement, or myeloma. So, what are the complications of AKI? Complications include hyperkalemia, metabolic acidosis, pericarditis, fluid overload, uremia, chronic kidney disease, and death. So, in summary, acute kidney injury, also known as AKI, causes an increase in creatinine serum levels and or oliguria or anuria. AKI can be classified into stage 1, stage 2, and stage 3. Causes of AKI can be split into pre-renal, intrinsic, or post-renal. Hospital management of AKI includes treating the cause, stopping nephrotoxic drugs, reviewing drug dosing, correcting hypothalemia, treating complications, daily bloods to monitor the AKI, and considering dialysis or filtration. Community management of AKI includes treating the cause, stopping nephrotoxic drugs, reviewing drug dosing, advising adequate hydration, assessing for complications, monitoring serum creatinine, and reassessing regularly for the need for a hospital admission. Complications of AKI include hyperkalemia, metabolic acidosis, uremia, chronic kidney disease, and death. Thank you for listening to the Little Medic channel. Don't forget, if you liked today's video, like and subscribe below. See you next time. Doodles!